So we're going to ask, I believe Dr. Catherine Lee is going to go first this morning. She is going to be discussing some follow-up recommendations for some common fractures. Catherine, are you on yet?
I'm here, Dr. Pat.
There you are. Okay. I just didn't see you on my screen. All right. Well, I will turn it over. Oh, CME color for today is going to be yellow. And I will put that in the chat right now if I can remember, and hope everybody has a nice weekend. And Dr. Lee.
Hi, everyone. I'm Catherine Lee. If we haven't met, I'm one of the PGY3s from the Orthopedic Surgery Department. And today I want to talk about when should follow-up and radiographs occur after distal radius and ankle fractures, and when should we break up with our patients. So the outline for this talk will be, we'll hit some basic science principles, talk about some review studies that have been done on follow-up, look at some specific studies on follow-up for distal radius and ankle fractures, and piece together what the economic impact could be. And finally, we'll recap some key points.
Hey, Catherine.
I am not advancing. I just noticed that.
We have you in presenter mode currently.
All right, All right, so we just went through the outline and I'll advance from here. So the basic science of bone healing starts with a fracture. Fracture healing depends a great deal on the stability at the site, which will determine mechanical strain. When the strain is below 2%, primary bone healing will occur, like with a compression plate. When the strain is between 2 and 10%, secondary bone healing will occur. And secondary bone healing occurs via endochondral healing and a systemic response. And of course, bone healing can occur through a combination of both, but endosteal and periosteal blood supply has to be available for stem cells to get to the site. The three phases of fracture healing start with the inflammatory phase. During this phase, the hematoma forms and is the source of stem cells and growth factors. Many cell types, growth factors, and cytokines migrate to the region and granulation tissue forms at the fracture ends. Patients usually report during this time noticing the most swelling post-injury prior to the beginning of weight bearing. This transitions to the repair phase, where primary callus will form from the granulation tissue that previously formed. This happens about after the 2-week mark. The soft callus forms in cases of relative stability, where osteoblasts form, and primary cortical healing occurs with end-to-end opposition and absolute stability. So kind of in the hazy period after the repair phase, the remodeling phase begins. And this starts at around day 16 to 21, but can continue long after the first evidence of clinical union. This is when the soft callus turns into woven bone and woven bone becomes more organized. The two important rules to consider during this time are Wolff's law, which states that bone remodels in response to mechanical stress, and that piezoelectric charges can occur in the bone and can affect healing and deposition. The compression side is considered electronegative and stimulates osteoblast formation, whereas tension side is considered electropositive and stimulates osteoclasts. Also, other factors can affect healing. The blood supply around the fracture is critical. The initial vascular disruption usually resolves around the 2-week mark and peaks around 3 to 5 months. Reperfusion of the area also matters. Studies have been done to show that nails that are not entirely canal filling can allow faster reperfusion of the endosteal blood supply. Mechanical factors such as bony soft tissue attachments, bone loss, and the inherent stability of some fracture patterns also contributes towards faster or slower healing. There have been some studies done on low-intensity pulsed ultrasound and bone stimulators, although exact mechanism of how they augment bone healing is not known. And then finally, patient factors such as tobacco usage, having diabetes, and medications also affect healing time. The basic science studies have shown that systemic corticosteroids have shown a 6.5% higher failure rate of intertrochanteric fractures compared to non-steroid users. And obviously, patient factors such as nutrition matter. If you believe this ad as seen on the internet, if you take these 5 herbs and treat your both bone forearm fracture with a hinged elbow brace and a cuff and collar, you can also have great healing. So before we talk about any kind of follow-up, we also have to discuss what fracture healing means to individual treating surgeons. This JBJS meta-analysis sought to kind of consolidate what the fracture healing literature shows. And what they found was an array of definitions for fracture union in the orthopedic trauma literature and a lack of consensus. Of note, they referenced 2 randomized prospective trials comparing antegrade and retrograde IM nails for femoral shaft fractures, which demonstrated different results. Ultimately, the patient population was similar, the injury was similar, and the treatment method was similar. But the only difference was that the studies referenced different time points for when, or different time points and different ways they assessed fracture healing. Additionally, plain radiograph is the most common way that they referenced assessing fracture union, but clinicians can't reliably determine the strength of fracture healing on the basis of a single set of radiographs. So therefore, we are relying heavily on a radiographic method without proven validity for predicting bone strength in the assessment of fracture union. Their conclusion was that in the future, instead of just having radiographic measurements, we need to incorporate an objective quality of life and functional parameters into the development of a more standardized definition of fracture union. So, out of the Netherlands, the Warrior trial has published extensively on follow-up of distal radius and ankle fractures. We will look at their distal radius data first. They looked mostly at radiography reduction, and Warrior starts for wrist and ankle fracture routine radiography reduction. It was a multi-centered randomized controlled trial using a non-inferiority design with two arms, one with distal radiuses and one with ankle fractures. They looked to see if healthcare costs could be reduced by reducing both clinical and radiographic follow-up for fairly routine fracture patterns. What they found in this study was that if they sorted patients into a usual care and reduced imaging care group, they all were seen at 1 week, 2 weeks, 1 week, 2 weeks, 6 weeks, and 12 weeks after either non-operative management or surgery, but that the reduced imaging cohort stopped getting radiographs after the 2-week mark because they felt that at 2 weeks, they would know if any loss of reduction or any kind of pivoting in the treatment algorithm would have to be done. What they found was that about 200 radiographs were saved in the reduced imaging cohort compared to the usual care cohort. The indication for radiographs, which were logged in both of these cohorts, were roughly the same. Fracture, dislocation, and checking for consolidation were the top 3 reasons why they got radiographs. So they had the same indications, but reduced imaging. And they saved on average for each of those patients about 1 radiograph per patient for these distal radius fractures. In an adjunct study, they found that this saved each patient about 49 euros, and with an incidence of 55,000 distal radius fractures per year, that was about $3 million in savings for the government. They also looked at whether or not routine radiographs change management. In this study, 841 radiographs were done, and about 721 were done for routine purposes for distal radius fractures. Of those, only 1.5% of those yielded a change in treatment strategy after the radiograph was done. So it indicated that routine radiographs probably were not meaningful to post-operative patient care in this cohort. When they looked at the ankle fracture cohort, they also wanted to see if they could eliminate radiographs after the 2-week mark, similar to the way they looked at for distal radius fractures. So they sorted them into a routine and reduced scheduling groups. Now for this one, everybody followed up at the 2-week mark, but for the reduced group, they did not get radiographs at the 6-week and 12-week mark like the routine group did. And almost every patient had a radiograph prior to the assessment of weight bearing. So they did have radiographs for like weight bearing assessment purposes, but not just for routine purposes. The outcome was that they were able to save approximately 1 radiograph per patient, as they saw in the distal radius cohort, without any statistical differences in functional outcomes. And this yielded a cost savings of approximately 52 euros per patient and up to $1.5 million annually for the government. So, what does this mean overall? Well, we can't discharge patients from follow-up if we can't let them weight bear yet. So this randomized control trial looked at early mobilization to see if there would be any detrimental outcomes or function to early mobilization and weight bearing. The standard of care for unstable ankle fractures has generally been non-weight bearing and cast immobilization for 6 weeks after surgical repair. Earlier weight bearing and mobilization is thought to expedite rehab and result in earlier return to function, but it has to be balanced with the possibility of wound complications, fracture displacement, or fixation failure. These patients were seen all at 2 weeks, 6 weeks, 3 months, 6 months, and 12 months. But at 2 weeks, they were either randomized to non-weight bearing for another 6 weeks or a walker boot and transition to weight bearing at the 2-week mark. Return to work was the main metric that they were analyzing, but they also got range of motion and pain and function scores. What they found was that there was no difference in time to return to work in the early and late weight bearing groups, but at 6 weeks postoperatively, the early weight bearing group had statistically and clinically superior outcomes in ankle range of motion, improved ankle function scores, and improved mental and physical health outcome scores, as seen in this graph here. And also, interestingly, they found that the patients who they let weight bear early had lower rates of hardware irritation and lower incidence of planned or performed hardware removal compared to the late weight bearing group. They posited that it was possible that early weight bearing decreased local scarring and decreased tendon and skin irritation around the plates and screws. Now, all of this matters because outside of the logistics of increasing or decreasing the number of follow-ups per patient in the radiographs, there's a consideration of cost. Many of the distal radius fractures and ankle fractures we see through CMC Maine are self-pay or sliding scale. So this study out of CMC Maine sought to look at the utility of radiographs at various points post-operatively after lower extremity fractures. The radiographs were sorted into 5 categories: immediately post-op, 48 hours post-op, but before the consideration for weight bearing, for the consideration of weight bearing, for confirmation of fracture union, and post-confirmation of fracture union. 88% of patients in this cohort received an immediate postoperative x-ray with an average of 1.2 sets of x-rays per single fracture due to the location of some fractures. These x-rays yielded a whopping 0.3% change of care. 100% of patients underwent x-rays in this study before the consideration of weight bearing, and that led to about 31% changes in care in the postoperative period. Now, 31% of those 31% were due to radiographic findings alone, and 22% of those were due to a history and physical element as well as a radiographic element. These results suggest that using routine radiographs in selected postoperative scenarios, such as weight-bearing progression or confirming fracture union, was useful, but that just having them immediately postoperatively might not yield as much information for the patient or for driving clinical care. They also found that an average of 2.23 radiographs could be eliminated from each patient's clinical course within this cohort. This again shows of the 31% that actually had change in management, only 31% of those were solely based on radiographs. So if we eliminate these 2.23 radiographs per patient, then we could eliminate their overall radiographic costs by about 50%, as this study found. And if we extrapolate this on a national level, it could be cost savings of over $370 million for a single year. Before we talk more about what the costs are, we have to understand what the services rendered look like. So office visits are classified as new patient, established patient, or consultation, and each is billed as either level 1, 2, 3, 4, or 5. This can be component-based or time-based. The 90-day global period encompasses a single payment for care associated with a surgical procedure. Now, what's included is pre-op care, pre-op visits, operative care, and bracing and immobilization done in the operating room, and some post-operative care consisting of progress notes and office visits. But what's not included is the diagnostic tests and procedures like CBC on post-op day 1. It also doesn't include the application of immobilization outside of the operating room and different visits for different problems. It also doesn't count reoperation for complications or stage procedures like front back spine surgery. So what that looks like for our patients is that after their 90-day global period runs out, here's the billing for an established patient out of the global period for atrium before insurance or sliding scale adjustments. As circled here are level 3, level 4, and level 5 established patients. Here are what an x-ray costs before adjustments for insurance or sliding scale. A 3-view of a wrist x-ray and a 3-view of an ankle x-ray are each about $100. I've also included the cost of CT scans for upper and lower extremities, and then also what a 3D recon with or without supervision costs after the CTs are done. Cast applications can also be associated with charges for these patients. I've circled what a wrist cast would cost and also what a lower leg splint would cost. So what happens if patients just simply don't show up because they can't afford it or because they're doing well? So this costs both time for the clinician and loss for the opportunity for another patient to be evaluated for their musculoskeletal problem. In a study done out of the DeBakey VA in Houston, they found that in the community, the average no-show rate was about 62 appointments per day in an entire practice, and the cost was about $3 million annually for that practice. In the training hospital setting, there's a reported 25% no-show rate and a 31% late arrival rate to appointments. So obviously this is the VA system, so a little bit different than our patient population, but collectively they cost in 2008 approximately $28.6 million for the VA system. Interestingly, they also found that the highest no-show rate was on Mondays and the lowest no-show rate was on Tuesdays. So ultimately what this means is good news for Dr. Karenacher's clinic and only Dr. Karenacher's clinic. With all of this information, is there an optimum plan? Is there a plan that we should adhere for distal radius fractures and ankle fractures that we see in our patients? There is evidence in the pediatric literature that untimely follow-ups have a wider monetary impact than just a clinic visit. So this retrospective review looked at pediatric referral patterns for pediatric patients with musculoskeletal injuries out of urgent cares and emergency departments. They found that 53 of these patients needed another visit after their first visit because 96.5% of them followed up either too early to confirm healing, too early to discontinue their immobilization, or too early to meaningfully alter treatment. The average cost per visit was $342, including transportation for the parents, wages lost, and radiographs and the office visit themselves. So over a year, the aggregate cost was $36,000 for all of the patients studied in this study. So while adult patients may not require a chaperone to every visit, many lower extremity fractures leave patients unable to transport themselves and require the assistance of family members, adding to that aggregate cost. And currently, there's little consensus in the literature describing routine fracture follow-up. This study out of JOT surveying OTA members on what they felt like appropriate follow-up would be for extra and intra-articular fractures yielded 184 responses out of 1,600 plus sent. But of those, they found that generally for extra-articular fractures, radiographic and clinical endpoint was about 6 months for the respondents. And for intra-articular fractures, the most common response for when they would be allowing their patients for discharge would be 12 months. So they concluded that most orthopedic trauma research studies should probably end at the 6-month mark, but should not expect patients to follow up past the 12-month mark. Knowing this, I wanted to see where we stood. So if you are a somewhat elderly person that stumbles into the emergency department with this fracture, you may end up in the clinic of one of these surgeons who may treat you. And this is what you can expect postoperatively. Across the board, the commonality is that within the first 1 to 3 weeks, there are frequent visits and frequent x-rays, which varies from 0 visits for the truly non-displaced distal radius fracture to 1 x-ray every week for the first 3 weeks for the ones that require significant reduction. Most everyone allows weight bearing and cast off by 6 weeks and the possibility of PRN follow-up by 12 weeks. Overall, everybody is likely to get radiographs early in care. If you happen to require operative treatment for your distal radius fracture by one of these 4 surgeons, this is what you could expect. Almost everybody sees their post-ops at 2 weeks for splint off, for suture removal, and then everybody sees theirs back at 6 weeks and 12 weeks for radiographs. The earliest possibility of discharge is at 12 weeks. And again, pretty close in plan for this cohort. Now, if you are a fun sports player playing a fun sport and you sustain a twisting injury to your ankle, you may have this isolated lateral malleolus fracture that is deemed stress negative by the junior resident on call. You could be referred to one of these 4 surgeons. Now, the follow-up plans here vary more, but weight-bearing status is consistently immediate weight bearing in a boot or an air cast right after. Radiographs are done once early in follow-up and then nearly after a month of weight bearing to ensure that no malunion or anything is happening there. They're usually considered for PRN follow-up somewhere in the 3-month range. Dr. Irwin's follow-up plan is as detailed by this paper in the Yellow Journal. Now, what happens if you fall a little harder and have a bimalleolar ankle fracture that requires operative fixation from one of these 4 same surgeons? The follow-up varies a little bit more here. Nearly everybody sees their patients at 2 weeks and 6 weeks, but the earliest weight-bearing consideration for a standard bimal ankle fracture, ORIF, goes to Dr. Harmer, who allows his patients to weight bear at 2 weeks based on this previously referenced paper. The earliest consideration from discharge from practice is about 6 to 8 weeks. Now, when I surveyed these surgeons and I asked them, has anything changed as you progressed in practice? The most common thing that was said was that they see their patients less frequently and are more amenable to PRN follow-up if the patients are truly doing well, even earlier in their postoperative course. So, what does this mean for what we've learned? Routine and clinical radiographic follow-up should be replaced by purpose-guided follow-up. So if you're allowing patients to begin weight bearing or to, transition to a different treatment, then radiographs are warranted. But perhaps routine radiographic follow-up is unnecessary for patients with routine fractures. Patients should be counseled on general follow-up plan if possible, so that they are not surprised that they may have to come back to clinic every week for an x-ray of their wrist. The cost of follow-up visits and radiographs can be high and should be avoided in patients if they're not likely to see any additional radiographic or clinical improvement. And as Dr. Kempton brought up when I asked him, virtual visits can assist patients who find it difficult to attend clinic in person due to distance or transport. So that may cut down on no-show rates as well as on the cost in aggregate for the patient. I would like to thank Drs. Ford, Garcia, Gart, Shu, Irwin, Karenacher, Kempton, Loeffler, and McKnight for helping me with this talk. And I turn it back to you, Dr. Pat.
That's great, Catherine. I think that we should have considered making you wait till October to give this talk, though, with that review of bone healing. Everybody could have had a little primer for the OITE. It's always interesting to, it's a great talk for people to really think about what their model is and how we should take care of things. But like everything in medicine, there's some different perspectives on it in terms of who should we be trying to protect, because obviously I think it was nice that you included those costs in there, because for a surgeon, especially in an independent practice, who's in the global period, who has basically no more income during that 90-day period, an office visit with x-rays, theoretically, while it's not a big money maker, it is some level of income for the clinic. Whereas if we're looking at sort of appropriate use criteria and, more of a hospital system based process, you wonder where that is. So it's interesting to think about. I don't think there's a right answer either way, but it's great data to look at. Any comments from any of our surgeons on the line who are actively treating these types of fractures consistently, especially if anybody has a different opinion?
Yeah, Catherine, I'll just chime in real quick. Great talk. I think, unfortunately, as Dr. Pat kind of alluded to, our country, as compared to some of those studies you referenced, has a little bit more of a defensive medicine culture. And I think, for better or worse, board examinations sort of force you into patterns of rigid follow-up early on, in particular with things like non-displaced or non-operatively treated distal radius fractures. There are publications which say you ought to get weekly radiographs. And I think that that's what drives a lot of our care early on in practice. And I think the reason you see trends toward less follow-up, less radiographs, is because we all realize it's not necessary, but we do it more or less because we have to in the first year of practice, because a board examiner can fail you for not doing it. So I think that that's where the change really needs to come, is good data that gets out into the public and widely disseminated that says that maybe this isn't all necessary.
You just wondered, Catherine, how things will evolve over time, because we also have a very orthopedic centric view of this. And if you look at a fracture like a clavicle fracture, I grew up and my dad was a family doctor. He took care of clavicle fractures frequently, since most of them were just treated non-operatively, and some of them I think would have, maybe even an initial visit with an orthopedist, but they would just tell them, yeah, you should be fine, it'll heal eventually. You wonder if we, change what we think are clinically significant fractures, and if we decide, hey, those non-operative ones can be followed by primary care sports, family medicine, and they can treat them functionally as much as anything. I think that it's just, what do we define as something that, quote, needs follow-up? Is that our orthopedic centric and our surgery centric culture? Joe, you have a comment?
Yeah, you actually kind of made it right there at the end. I think we have some incredible sports medicine injury clinic colleagues that do primary care sports medicine. And frankly, for some of these non-operative fracture patients, my patients have actually been happier in that setting than getting thrown into giant post-op, pre-op clinics in our setting. So I think it's worth considering in our setting, especially because I think their throughput is a little bit more efficient. Patients get a good patient experience and likely, don't really need to see an orthopedic surgeon.
Yeah, I was just looking through our list to see if Dr. Burrows or Dr. Price or anyone was on the call to see if, see what their thoughts were. Maybe an interesting, future topic for grand rounds about, how do we treat simple fractures in the community, and is that a viable alternative and reasonable place to get another way of doing things. But T, did you have a question before we move on to our next lecture?
Actually, more of a comment. Our primary care sports colleagues are critical to the network we're developing in sports medicine, and you may know that we're growing that network pretty rapidly. But I just wanted to announce something real quick related to primary care, and you gave a great lead in, Joe. Rob Lutz was just awarded yesterday a Teal Acorn Award. As you all know, that's the highest honor that we get in our system. So congratulations to Rob, one of our primary care sports docs who was named the Rookie of the